Here at the AUA 2018 conference, welcome to our interview, Prostate Cancer Focal Laser Ablation, a view from 30,000 feet. We are delighted that we have Dr. John Feller here today. Our speaker is a founding partner at Desert Medical Imaging. Dr. Feller is board certified as a diagnostic radiologist with subspecialties in orthopedic and sports medicine imaging and body MRI. After completing a bachelor's degree in metallurgical engineering and material science at the University of Notre Dame, Dr. Feller graduated summa cum laude from the Ohio State University School of Medicine. Then an internship, residency, and fellowship training at Stanford. Dr. Feller has co-authored many peer-reviewed journal articles and has been invited to over 300 lectures. Thank you, Dr. Feller. First, before we discuss lasers and energy source, what is your opinion as to using focal treatment for prostate cancer?
Well, thanks, John, for the invitation to meet with you and speak about focal therapy today. You know, up until recent years, the initial treatment of prostate cancer just was two ends of the spectrum. We had either the option of active surveillance at one end of the spectrum for low-risk prostate cancer, and then at the other end of the spectrum, we just had whole gland therapy, so radical prostatectomy, whole gland radiation therapy, various forms of brachytherapy. But we didn't have anything in between that was organ sparing. In 2018, we have the emerging potential for therapy using focal treatment for prostate cancer. That's very exciting because it gives us an opportunity to preserve more function and at the same time pursue reasonable oncologic control.
Thank you. Who in your opinion, is typically a candidate for focal treatment?
So the typical patient we see that we feel is appropriate for focal therapy is a patient who has intermediate risk prostate cancer that's organ confined. So usually that's going to be a Gleason 3+4 or 4+3, so grade group 2 or 3, or patients who have large volume Gleason 3+3 disease, all of which is considered to be organ confined. Also, it needs to be visible with imaging so that it can be treated with focal therapies under image guidance. These patients typically also are interested in a balance between functional outcomes, so that they're concerned about the side effects that can potentially happen with whole gland therapy versus the cancer control part of things. So many of these patients become interested in focal therapy and are candidates for it because they're interested in minimizing the side effects of whole gland therapy, assuming that they can have adequate cancer control.
What is laser interstitial thermal therapy, or focal laser ablation, or simply FLA?
These are terms that apply to what we now call laser focal therapy. The laser interstitial thermal therapy initially was kind of the scientific term we use for using interstitial laser, usually a diode laser. The laser that we use is about 980 nanometers to use thermal therapy to treat the prostate cancer. This therapy is performed directly inside of an MRI machine so that we can use MRI thermometry to monitor during the performance of the therapy. This really improves the safety of the procedure. We can literally monitor the temperature and where there's irreversible damage, really real time in both the axial and the sagittal plane. We can also put safety cursors using this technology on important structures like the rectal wall and on the external urethral sphincter, and the laser will literally shut off if these structures start to heat up. So in summary, laser focal therapy is a way to use thermal therapy administered using a laser that can be placed either transrectally or transperineally, and under MRI guidance then treat the cancer focally.
Inside the U.S., is FLA offered solely in investigational clinical trials, or is it also available in a retail setting?
It's actually available in both settings. Most of the laser interstitial focal therapy is being done as part of IRB-approved clinical trials because we're trying to get additional data about oncologic outcome, how well it controls the cancer over time. But because there's a general FDA clearance for the device for necrotization of soft tissues, including urologic applications, it is possible to use it on label in a commercial setting, and there are some sites that are doing that.
As a follow-up, It's my understanding that typically FLA is not recognized as a standard of care treatment, so reimbursement is typically problematic. Would you agree?
Yes, yeah, we've not really successfully had any reimbursement from CMS/Medicare or from the commercial payers in our experience over the last 8 years.
Is there also an appropriate alternative in salvage situations?
It is. Our clinical trial at Desert Medical Imaging includes both treatment-naive patients that have intermediate risk prostate cancer that's organ confined and MRI visible, but we also have a salvaged limb. And in the salvaged limb, we've treated patients who have biochemical recurrence of their prostate cancer that includes local recurrence that we confirm with multiparametric MRI and with an MR-targeted biopsy. That then we've been able to go in and laser the local recurrence. And we've done that in patients that have local recurrence after radical prostatectomy, after LDR brachytherapy, after external beam radiation therapy, after proton beam therapy, after whole gland HIFU therapy, and after thermal therapy. So we've seen a wide range of patients where basically all other options have been exhausted in terms of typical standards of care that we've treated with salvage therapy and had some very promising results that we continue to follow.
I'm curious, we have a number of energy sources that might be used for focal treatment. We have cryo and HIFU and others. Why did you kind of have an interest in exploring laser as an energy source?
So 2 words, precision and safety, is why we got interested in laser. I'm half Swiss in terms of my background, my heritage, and I appreciate things that are very, very precise. With laser focal therapy, because we have real-time thermometry that's monitoring the patient in 2 different planes while we're treated, we can be very, very precise about exactly where the thermal therapy and the coagulation necrosis occurs. So we can actually treat cancers that are far out in the apex, very close to the external urethral sphincter safely. And we can also treat very, very large glands. Laser does not require any sort of a mini TURP or a gland reduction procedure. We've been able to treat glands that are over 200 cc's in size and reach cancers that are located at the base, mid-gland, or apex levels, whether they're posterior or anterior in location. So precision is very, very important. And then the safety part also. Because we use this real-time MR thermometry in 2 different planes, and because it has these safety cursors that we can put on structures like the rectal wall and on the external urethral sphincter, even if I don't see damage occurring in those areas, with those safety cursors, if those structures start to heat up too much, the laser will shut off. And as a result of the safety profile and the precision, I think that's really why, for example, in our trials, we haven't had any serious adverse event or complication that's occurred. No rectal fistulas. We don't have any statistically significant erectile dysfunction or urinary incontinence at this point. And we really think it's because of the safety profile of laser and its precision. We use a phrase, sculpting a therapy with laser. We're actually able to very, very carefully treat sometimes very sensitive areas with this technology.
And as I understand it, laser is generally performed using in-bore real-time guidance, where some other modalities are trying to offer that, but they're really more in a clinical and early setting to evaluate whether it might work for other energy sources. Is that accurate?
Yeah, most of the phase 1 and phase 2 trials that have been done using laser, either transrectally, which is the way we do it, or transperineally, were done in-bore. But there are also a completed kind of safety and feasibility trial using fusion to perform this. So there's some very early results with 1 or 2 programs that are looking into whether this could potentially be done in office using fusion technology. But for now, most of the experience, and certainly our experience in 8 years of follow-up, is based on in-bore laser focal therapy.
In the spirit of disclosure, I probably should mention that I'm a healthcare actuary, and in 2014 I was diagnosed with 3 bilateral lesions with Gleason scores of 6 and 7, 3 plus 4. Doctors from various specialties were unanimous on one issue only, that I was not a good candidate for active surveillance. but radical prostatectomy level 1 evidence showed little, if any, advantage to my expected longevity. And really, that's where I was in a conundrum. Should I have the active surveillance approach, which might be undertreatment in my case, or should I undergo radical whole gland treatment, which might be overtreatment? And again, as an actuary, I've looked at the level 1 evidence studies on whole gland treatment versus active surveillance, and as an actuary, I was in a conundrum. In any event, upon further review, my thought process was to, number 1, destroy the current lesions, number 2, minimize side effects, and 3, preserve future treatment options. The unknown long-term oncologic evidence was kind of interestingly not an issue for me. Now, 4 years later, I have no evidence of disease and no change in quality of life. And again, that's anecdotal, but I thought I just want to share my own perspectives. Doctor, also as we proceed, I'd like the audience to appreciate that the FDA has strict restrictions as to what can be discussed regarding clinical trials. In light of that, can you provide an overview of your trial's design, that is eligibility, protocols, and endpoints?
Sure. So we completed a phase 1 trial in 100 treatments that showed that essentially the transrectal outpatient laser focal therapy with MR guidance is safe and feasible. That's completed. We're now in a phase 2 trial that includes an accrual of 1,000 patients. We're up to 119 patients so far. It's a 20-year study. We have 8-year interim results that we just presented here at the AUA meeting that show that, that if you biopsy the treatment site following laser focal therapy, 6 months following the therapy, about 18% of patients in our trial have some residual or recurrent cancer. And those patients typically we manage depending on what the Gleason score is and the volume of the tumor and whether or not it's MRI visible. If it's a higher Gleason score focus that the patient develops over time than what they started with, which happens in about 6% of our patients, we move them over immediately to whole gland therapy. If it's a low volume, low risk Gleason 3+3 focus that in particular we don't even see with the follow-up multiparametric MRI, that typically will be managed with active surveillance. If they have intermediate risk prostate cancer that's still organ confined and is residual or recurrent, then we'll retreat those patients with laser. So the protocol essentially calls for a vision where we're trying to see if we can convert intermediate risk prostate cancer into a chronic illness, where you have your follow-up PSAs, your follow-up multiparametric MRIs. If you develop some new abnormality, you get a targeted biopsy, and then the treatment is determined based on that. But we're trying to investigate whether or not that provides adequate oncologic control over a 20-year period. And we're 8 years into that, and at this point that initial treatment has provided satisfactory short-term and intermediate oncologic control in about 78% of our patients.
As you know, patients who choose focal treatment strongly value quality of life. So how can we measure side effects and complications?
It's a great question. I mean, one of the, there's 2 types of outcomes that are being looked at with focal therapy. One is functional outcomes, the other is oncologic outcomes. The functional outcomes are used, the tools that we use are called PROMs, the patient questionnaires that they fill out, the IPSS score, the SHIM score with regard to whether or not they have incontinence or whether or not they have any erectile dysfunction. So these questionnaires are filled out actually at 3 months, 6 months, a year, and then yearly by our patients. And this provides us with a functional outcome to look for whether or not there's significant side effects associated with focal therapy. In addition, obviously, we monitor whether or not there are any serious adverse events that occur as a result of participation in the trial. So far, we haven't had any serious adverse events related to laser focal therapy. And as I mentioned earlier, we haven't had statistically significant erectile dysfunction or urinary incontinence in these patients.
Following conventional whole gland treatments, salvage treatment may be necessary. These are complex with significant toxicity risk. And some experts, such as David Woodrum at the Mayo Clinic, estimate durable remission at only about 30% after 5 years following salvage after conventional radical whole gland. If treatment is needed after FLA, what options are available, and are these procedures made more complex by the prior FLA?
That's a great question. One of the real big advantages of laser focal therapy that we've realized is that it retains the potential for both whole gland therapy down the road if needed, or repeat laser focal therapy, either one. So as I mentioned, 6% of our patients have developed an incidence focus of prostate cancer that was higher Gleason score than what they started with and warranted being moved over to whole gland therapy. Most of these patients we've sent to local university program where we get feedback from the urologist in terms of any technical difficulties they experience doing the robotic-assisted radical prostatectomy. In every one of those patients, the urologist has called us back saying that if we had not told them that the patient had had laser focal therapy, there's no way that they would have known that, and that the surgical procedure was not compromised in any way by the fact that the patient had had previous laser focal therapy. And then for additional laser focal therapies, the patients who have residual or recurrent prostate cancer that's intermediate risk, those patients we retreat with laser, and we've had no technical difficulties going in and actually retreating them.
In terms of next steps, you already mentioned that you're in the middle of a long-term trial, and of course the follow-up is going to be very interesting. Is there any other plan to expand the scope, perhaps in terms of number of sites?
Yes, so the plan to expand sites includes creation of an international laser network, which has multiple sites. We've agreed to a protocol. The protocol and the informed consent document has already been approved by 3 different IRBs that are participating, that are sites that are participating in the laser, the International Laser Network. So a multi-institutional study is the answer to your question about what we're pursuing next. And then in addition, we really need to completely wrap our arms around the oncologic control by having further follow-up with the phase 2 trial that we're doing that's going to include 20 years of follow-up. But we're already 8 years into that and looks very promising.
Well, this has been very interesting and useful feedback, and I appreciate it. But before we wrap up, what vision do you have in terms of a crystal ball and possibly next generation modalities?
So for me, the crystal ball is whether there's kind of two different tracks of what we need to do in terms of the roadmap. One is to reduce the marginal residual/recurrence rate by improving treatment planning. We all know that MRI underestimates the size of the prostate cancer by as much as 7 to 9 millimeters, and the tumor volume by as much as 30%. So improving treatment planning, in other words, how large a margin do we need to put around the MRI abnormality to have adequate cancer control? That's one area where a lot of work is being done. The second area is interest in combination therapies. It may be that laser focal therapy or other forms of focal therapy can be combined with intratumoral immunotherapy or oncolytic virus intratumoral deployment, or some other form of therapy that can be combined with focal therapy to reduce potentially these marginal recurrence rates, to potentially increase and improve oncologic control over the long haul.
Doctor, that basically concludes the questions. You've been very complete in your answers, but are there any additional comments you might have?
No, there's a Chinese proverb that says, may you live in interesting times. I think we live in very interesting times to improve the care for our prostate cancer patients, to not only pursue therapies that improve the functional outcomes and reduce side effects, but at the same time have the potential to provide adequate cancer control. And these new focal therapies are a very exciting research opportunity.
To conclude things today, basically what I'm hearing is that while there may be considerable debate over focal treatment and more research is needed, new MRI-based technology may transform how prostate cancer is diagnosed and treated. Dr. Feller, you and your colleagues at DMI have been pioneers in this arena with out-of-the-box thinking balanced with rigorous research. And today, as always, you have done an outstanding job in sharing your experience. Thank you.
Thank you.